So I'm going to chat with you about mostly clinical and some molecular determinants of outcomes for people with NF1 who develop non-optic pathway gliomas. And specifically, we're going to chat about adults with NF1-associated tumors. I don't have any financial or competing disclosures. Just as a very brief background, we all know NF1 is a tumor predisposition syndrome that puts patients at risk of developing both benign and malignant tumors. And CNS tumors are really overrepresented in people with NF1. In kids, we know that optic pathway gliomas are common. In adults, high-grade gliomas are a little bit more common than the non-NF counterparts. Unfortunately, the natural history of these NF1 gliomas, specifically the non-optic ones, is not really well understood. And that poses many, many challenges, including that no standard treatments are available yet for this population. We tend to borrow a lot from the sporadic gliomas, but as you'll see from my conversation with you today, but there's really no standard treatment for people with NF1. So in order to understand these tumors a little bit better, we conducted a multi-center study with adults with NF1 who developed a non-optic pathway glioma, and this is a retrospective study. The objectives of this study were to evaluate the overall survival of adults with NF1, that's 18 years of age or older, with a histologically confirmed tumor. And we wanted to, as secondary objectives, look at the distribution of those histologic subtypes, what kind of tumors were they developing, and also evaluate the prognostic relevance of the commonly used variables to predict survival in the sporadic glioma cases. So histologic diagnosis and WHO grade, extent of resection, age at the time of diagnosis, the performance status, tumor location, and molecular data when available. With this being a retrospective study, we were missing a lot of the molecular data, and we were looking back since 2000. So the 20-year interval didn't lend itself for a lot of molecular data being available, especially for the early cases. And lastly, we wanted to evaluate the treatment patterns that were used and the response to therapy. So we evaluated any patients from 2000 to 2019 who were treated for a glioma and in the setting of NF1 at Johns Hopkins, Memorial Sloan Kettering, and Washington University. And we collected retrospectively data on their clinical presentation, how they were treated, if next generation sequencing or immunohistochemistry stains were available. We did that as well. We took that information and evaluated their radiographic monitoring studies as well as their survival. We recruited 3 neuropathologists, one from each of our institutions, to review all the slides together and evaluate how difficult or not it was to grade and classify these tumors, and I'll talk to you a little bit about that. And then we analyzed the data using statistical methodology. We were able to recruit 41 patients that met eligibility criteria. You see that the sex distribution was pretty fairly distributed, with 21 females and 20 males. The median age at diagnosis was 32 years of age, which as you can see is surprising for a glioma population. The median Karnofsky performance status was 80%, but it ranged from 30 to 100%. You'll see that some patients were asymptomatic, and it was an incidental finding at the time of diagnosis. But usually they presented with symptoms, and the more common ones were headaches, ataxia, visual disturbances, sensory deficits, and dysphagia. But we had many, many different presentations, including hiccups, and like I said, asymptomatic patients that were getting MRIs for evaluation of a known focal area of signal intensity, also known as a FOSI or a UBO, common findings in people with NF1. One of our objectives, as I said before, was the distribution, learning about the distribution of the kinds of gliomas that our population had. And as you can see, the more common ones were diffuse astrocytoma, WHO grade 2, and glioblastoma in 26 and 20% respectively. But we also had a few cases, that 14% here, others, that were a wide variety of things, including an embryonal tumor, neuroepithelial tumors, poorly classified. And there were 6 cases out of those 41 where the pathologist actually really struggled to classify them, as they did not meet any of the classical features from the WHO classification. So you can see here pilocytic astrocytomas and high-grade gliomas with pilot features and anaplastic astrocytomas were also relatively common. And feel free to stop me and unmute yourself and ask questions as I'm talking to you guys, so I can answer questions. I'm happy to do that. IDH status was something we explored, and we expected them to be IDH wild type. 100% of the cases that we've seen of gliomas in the setting of NF1 are IDH wild types. Unfortunately, next generation sequencing was only available in 10 cases, and it varied widely what kind of genes and panels were tested or used. But as expected, in those who had an NF1 gene mutation tested, it was present and it was pathogenic. Additional variants included amplifications or mutations in EGFR, ATRX, CDK2A, NB, P53, TERT, and MSH, among others. MGMT promoter methylation status was only available in 11 cases, out of which 7 were unmethylated. One of the interesting findings, we kind of had an idea that most tumors would be located in the midline structures, but it was a little surprising that 70% of the cases were located in one of these structures, either brainstem, thalami, basal ganglia, or spinal cord. We weren't expecting such a high percentage of cases of midline gliomas. This is diffuse astrocytoma, whole grade 2. You can see that it is T2 and FLAIR hyperintense, but had minimal to no contrast. But in case 2 and 3, these are also diffuse astrocytomas, and you can see that there are patchy areas of enhancement that we can see and affecting the brainstem, the midbrain there, and the thalami with extension to the midbrain in this case number 3. Case 4 is a tumor which was poorly differentiated and difficult to classify. It had some neuroepithelial features and gangliocytic features as well. That patient did relatively well after resection. Case 5, unfortunately, was a case of glioblastoma, and you can see kind of that typical classic butterfly distribution crossing the corpus callosum with some areas of contrast enhancement and T2 and FLAIR hyperintensities. This is a case that was really interesting to me, a patient who was about 40 years of age at the time of diagnosis, who presented with this contrast enhancing lesion in the cerebellum, in one of the cerebellum hemispheres, very close to the peduncles, who started treatment after a biopsy with trametinib. He did not receive any frontline therapy with cytotoxic medications or radiation. And after receiving trametinib, soon after, he almost had a complete response where his tumors, the areas that were enhancing, almost completely disappeared. Unfortunately, the response was not well sustained, and after a few months, he started developing worsening of his condition. But he stayed stable for a pretty long time, and either stable or had some stable disease for a little while. Here is a case of a patient that I just saw recently, just a couple of weeks ago. He is not a case that was included as part of the study, but I thought it was interesting to show because it is also another patient who received frontline therapy with a MEK inhibitor as opposed to STOOP therapy with temozolomide and radiation. And you can see the progression of his disease. This is a patient with neurofibromatosis type 1. He is 21 years of age, presented with a hemorrhagic stroke that was later found to have an underlying tumor. Pathology was done in May. He had a gross total resection, beautiful resection, and he had a low-grade astrocytoma with pilocytic features, but there was something unusual about his histology. And as you can see here, which was pretty unexpected for a pilocytic astrocytoma, he started having recurrence of the tumor pretty soon after the surgery. And again, this is real recurrence. This is not pseudoprogression, as the patient had not received any radiation yet, or hasn't received any radiation at this point. We spoke with him about the natural history of these tumors and that we don't understand it very well, but in some cases we've seen that even low-grade gliomas can have a more aggressive clinical course in the setting of NF1. So he ultimately decided to start treatment with MEK inhibition, in this case with selumetinib, and we can see just within a month after starting treatment, this is late November, just before he started the selumetinib, and after a month of treatment, his tumor had significantly decreased in size. Going back to our study, the extent of resection, given that the cases were mostly located in the midline, were mostly biopsies with a few subtotal resections and very few gross total resections. Most cases had chemotherapy and radiation administered by a portion of them. About a third of them only received surgery as treatment and were monitored until disease progression. Radiation therapy as monotherapy was also administered in a very small percent of patients. And there was one patient in which we made recommendations of using chemotherapy, but he was lost to follow up. We only found out that he passed away a few months later, so we included him for survival analysis. The antineoplastic agents, for those neuro-oncologists here interested, that were used were 15 cases of temozolomide, trametinib as frontline therapy in 4 cases. Some people used bevacizumab, carboplatin, and procarbazine, either monotherapy or in combination for the treatment of these patients. 5 complete radiographic responses were seen, but most of them were either stable disease and some partial responses or disease progression. 13 patients were still alive at the time of the analysis and were censored at the last time of follow-up, with a median survival of 23 months, which is a little bit better than our glioblastoma population, but still, this is a mixed group of patients and histologies. This is the Kaplan-Meier curve for the entire population for those in whom we had survival. As I said, the median was 23 months, ranging anywhere from 2 to 109 months. This is Kaplan-Meier survival analysis based on the WHO grade. And as expected, those with grade 4 and grade 3 tended to do more, tended to do poorly, but still not as poorly as their sporadic counterparts. Ki-67 was the only part of our analysis which was significant, statistically significant, with a higher percentage of people passing away at earlier stages if they had higher KPS. But the other prognostic factors that we commonly use were really not statistically significant, although of course this is a small population. Again, this is another Kaplan-Meier according to histologic grade, regardless of their WHO classification in terms of grading, but most of them followed the traditional grading of glioblastoma being 4, pilocytic astrocytoma being grade 1, and diffuse astrocytomas being 2. Resection was really not statistically significant. Whether they had a biopsy or a gross total resection didn't make much of a difference, but there was a tendency for a better survival when the biopsy with gross total resection versus biopsy. And age, again, did not play a significant role in how these patients fared. We did the analysis by dividing the group into those who were greater than 40 years of age or younger than 40 years of age. So in conclusion, non-optic pathway gliomas in adults with neurofibromatosis type 1, even those that are low grade, can have a more aggressive course than expected. And this has been seen in other studies. This is the larger population that is published. It's not yet published, but it's been submitted for publication. But this is the largest cohort of patients with histologically confirmed gliomas in adults. It's a little bit different from kids, but our findings are supported by other studies that are out there that are smaller. And tissue diagnosis based on morphology coupled with molecular data is likely to improve prognostication. So we hope that as we move forward to more NGS collections and sending for genetic testing, this will improve with time. And that will in turn, hopefully, improve how to monitor and select treatment protocols for these patients. But we still need further evaluation, and a systematic and prospective evaluation of the natural history of people with non-optic pathway gliomas in NF1 is clearly necessary to understand and treat these patients better. So with that, I'd just like to acknowledge everyone from the 3 institutions that participated at Hopkins, MSK, and WashU. All of them were instrumental in the collection of data and the analysis of this study. And I'm happy to take any questions if there are any.
Great job, Carlos.
Really nice talk, Carlos.
I had to step away in a couple minutes, but I just want to ask, do you think the new World Health Organization classifications that are coming up later in the next years, do you think these patients should have their own category of subtype of glioma?
Yeah, I think so. I really think of these people with NF1 who develop a glioma as having a completely distinct entity compared to the non-NF counterparts. They have different response to treatment. They have different overall survivals. Their molecular features appear to be different. But again, there's a lot to be learned. But I do think that at the end, we'll learn that these are completely different entities compared to the non-NF counterparts.
Sounds like the next C-impact.
Yeah.
Carlos, my question is related to what we discussed earlier, targeted therapy and combinational therapy. Has that been attempted with NF2 gliomas, like combining solanezumab or trametinib with Temodar, standard of care?
That has not been, there is no prospective study in adults using combination therapies. There are some clinical trials that are ongoing and that will open soon in pediatric population where there's combinations of MEK inhibition with other agents. And Dr. Schreck is here, so she's going to talk.
Right, I figured that that's probably, I can wait till her talk. She may.
But these patients don't have a BRAF mutation. It's extremely rare that they have a BRAF mutation. So maybe Carissa will shed some light into those BRAF inhibitors that are not paradoxically activating the MAP kinase pathway in people without a BRAF V600E mutation. But it'd be interesting to explore that and combinations with other targeted therapies, including mTOR inhibitors or SHAPE2 inhibitors, things like that. Those combinations tend to be very toxic, but that's a potential avenue for evaluation.
Right. Great. Thanks. Great talk.
Thank you.
Thanks.